The literature shows after a brain injury, using binocular occlusion can help cause a visual frame of reference. And so the patient is still able to utilize their full visual field, but they have small pieces of tape here that are able to anchor their vision essentially. And so typically with those patients, and this is in concordance with a neuro optometrist or ophthalmologist, those are going to be smaller. For what we use in our an outpatient, and again, these aren't necessarily patients that have an acquired brain injury. These are patients that have peripheral vestibular disorders and also have motion sensitivity. We'll use the nasal occlusion a little bit thicker, almost to impair some of their central vision. And the reason why is because you really want to encourage central peripheral integration. And a lot of our patients with dizziness become very centrally bound. When you feel dizzy or when you feel fearful of falling, you start focusing in a really small area, and you can even see some postural changes. And so by temporarily occluding some of the central vision, of course, you don't want to cover their whole glasses. You're kind of encouraging them to use more of that peripheral information for where they are in space, which is also going to habituate them. And so the way that there was a question earlier about how do we know to use that. Sometimes we'll simply put a pair of glasses on the patient and have them repeat an exercise that didn't give them any symptoms and see if it changes, see if it causes more symptoms now that they're utilizing those peripheral vision. So hopefully that makes it clear on how the two different things are used. One is used as a visual anchor for acquired brain injury, and that's you're going to be working with a neuro-optometrist or a neuro-ophthalmologist. And then the other is more of a way to kind of open the patient's field of vision and utilize peripheral and central integration.